#Health is proudly supported by the University Students' Council at Western University. Hi, you're listening to #Health. This is a show where we combine academic literature with expert opinion to address trending health topics. In this episode, we'll be discussing something that a lot of people try to avoid talking about, the end of life. We'll be investigating what you experience as you approach the intersection between life and death, and how we can reach you once you've crossed over to the other side. Well, sort of. Imagine you've gotten into a horrific car accident, and you feel your life slipping away as the wreckage compresses your broken body. You don't think you can keep clinging on much longer. Someone manages to pry you away from the heavy metal scraps and starts desperately pumping your chest, pleading with you to stay with him. But you can't. Things start to fade, the sounds start to drown out, and your consciousness dissipates. Next thing you know, you're rising up and you look down and see someone performing CPR on your lifeless body. You continue to ascend and gradually feel yourself being engulfed by intense pulsations of serenity and love. You're then greeted by mystical beings that you've never seen before, but you feel as if they've known you your entire life. By their presence alone, you feel completely at peace and are ready for your consciousness to merge into infinity. But then you start to notice the mystical beings departing, and that whirlwind of tranquility that you were wrapped in starts to disappear. You're falling back down, straight for your body. Next thing you know, you open your eyes to the same man massaging your chest. He and many onlookers start to cheer, yet you can't help but want to go back. It was nice while it lasted. The first thing we're looking at is near-death experiences, which is a topic surrounded by a lot of mystique. Vivid accounts from people who have stared death in the face and ultimately lived to tell the tale are met with public awe, wonder, and inspiration, yet also a fair amount of skepticism too. The people who have claimed to have been on the brink of death have fascinating stories that end up becoming New York Times bestsellers and are shared by millions on social media by people looking to reinforce their own faith and spirituality. There's no doubt that near-death experiences are incredibly important, defining moments to the people that have them. However, it's worth asking what goes on behind the scenes when you're having a near-death experience. What is your brain actually doing? And to answer that question, we have Dr. Kevin Nelson. Dr. Nelson is a neurologist and professor at the University of Kentucky who has been interested in the topic of near-death experiences for some time. And he's the author of the book, The Spiritual Doorway in the Brain, A Neurologist's Search for the God Experience. Let's hear what his take is on exactly what a near-death experience even is.
Now, let me tell you I think it's important for us to understand that the principal misnomer of the near-death experience, and that is that only about half the time the near-death experience actually is a near-death experience or someone is medically threatened. The other half of the time, it is not, someone is not near death, they are not being medically threatened, but the brain has reflexes and evokes processes that are critically important for, in large measure for survival as part of our fight or flight response. But in fact, only half the time are people who have a near-death experience actually near death. Now, a very intriguing study was undertaken in the early 90s and published in Lancet, which is a highly reputable journal. And they looked at the health records of about 58 people who had near-death experiences, and they found that only half of them were actually medically threatened, and the other half were not. And what they found with these two groups, those with true medical threat for their near-death experience and those not, they found that the experiences were extraordinarily similar. One of the things that is a central tenet to all neuroscience is that the brain is responsible for all human experience. Now, there is no scientific proof that we can have human experience outside of the brain. If that happens, that's a matter of faith. And I'm not saying it doesn't happen, it's just that it has no scientific basis for this. So when I've heard physicians, other physicians and certainly lay people who have said that, well, this experience can't be explained by brain-basis processes, and that's incorrect. Everything that I have heard of can be understood in terms of how the brain functions. There is no scientific evidence that we are capable of having human experience outside of our brains.
So it's pretty clear that Dr. Nelson is not convinced that the consciousness actually leaves the body in a near-death experience. He essentially says that any explanation for what is happening in that moment is contained in the brain and nowhere else. But many people who report near-death experiences describe an out-of-body experience as part of that, where they float up and can stare down on their own physical body. One famous case is that of Pam Reynolds, who needed a highly complex surgery to remove an aneurysm at the base of her brain, which involved cooling her body down enough to stop her heart and draining the blood from her head. This is called the hypothermic cardiac arrest technique, which is meant to keep cells alive when they're not getting enough oxygen. To make sure that all activity in the brain was gone, doctors blasted continuous clicking noises into her ears at 100 decibels, which is the same thing as pretty much the sound of a jackhammer. When the sound didn't trigger any brain activity whatsoever, they could be sure that she was effectively dead. Yet once they rebooted her by warming her back up, she said she had an out-of-body experience and could see the medical team operating on her body. She was able to describe details like the shape of the bone saw used on her skull, conversations had between the surgeons, and the song that they played while they were operating, Hotel California. Out-of-body experiences can be extremely profound, and some tout it as proof that the near-death experience can't simply be confined to only the brain. Let's see what Dr. Nelson has to say about them.
First off, let me say that they're common, extraordinarily common. Now, what does a neurologist mean by extraordinarily common? Well, it means that 1 in 20 people have had an out-of-body experience in their life. Let me give you a few contexts that have been common in my subjects and in my patients. Most of the time, out-of-body experience happens in that transition between REM consciousness and waking consciousness. Now, there are only 3 states of consciousness that the brain's capable of. That's waking consciousness, non-REM sleep, and REM sleep. So when you're coming out of REM sleep, usually in the morning, last thing in the morning before you wake up, sometimes that transition gets kind of not so normal, where you will have elements of both REM and waking consciousness kind of blending, and so during that you can be paralyzed, like what's called sleep paralysis, and there's a lot of different common cultural terms for that. But during that time, people can have an out-of-body experience, and it most often happens when you will have a visual sense that you are above your body, and what we think is that the sensations of your body get disconnected from your vision and your balance center, what we call the vestibular system, your position center, and your vision disconnect from one another, because those are all integrated in a little area called the temporal parietal area. So when that integration doesn't take place, your vision and your sense of where your body is in space through your inner ear and knowing just where your left foot is right now, all that gets uncoordinated. And so the body puts it together in a scrambled way, and that scrambled way is an out-of-body experience. Now, those are relatively common because of the relationship that out-of-body experiences have with the REM consciousness. Now, how people see this varies on when the out-of-body experience happens. If it's while you're waking up and you have an out-of-body experience, you're lying in bed, you may just think it's just the oddest thing you've ever had, and just odd, not necessarily spiritual, not necessarily frightening, although a lot of people are frightened by it. In fact, people with disorders of REM consciousness, narcolepsy or sleeping disorder, where this happens quite a bit, they can have out-of-body experiences every week. I mean, and if you treat the narcolepsy, those out-of-body experiences tend to subside. But they can happen usually when people are lying down and when they're resting, but not always. I mean, people have reported them when they've been walking. In fact, I think one of the striking ones was another neurologist who told me about his out-of-body experience. And at this time, it was before he went into medicine, and he was a fighter jet pilot. And he was piloting a fighter jet, and there's a lot of inner ear and a lot of sometimes, you're about to faint. And he suddenly had an out-of-body experience. He was outside of the jet, looking down on the jet as he was piloting it. Now, is that really happening? I mean, we've had some people that have wondered if, in fact, that is your consciousness that's floating out there, and the answer, no, it's actually a visual reconstruction. He doesn't believe he was actually out of the jet, flying the plane. The plane didn't crash, by the way. It was not a return from death experience. But in fact, he landed fine, and there's a perfectly sound neurologic explanation for that. People will construct a lot of their visual surroundings by memory, and they may actually have their eyes open, but it's the reconstruction of it by the brain is disorganized. As a neurologist, what I have found is that people are oftentimes a lot more alert than is apparent to the medical staff or the medical personnel attending the patient at the time. And they're often, even if you faint, people's eyes remain open. So if you're not quite fainting, but you're losing your tone, your postural tone, and you're slumping, your eyes can be open. You can be taking in a lot more, even though you're not responding, and it looks like you're unresponsive to the externals. And a lot of times, medical personnel they're preoccupied with direct matters at hand, like cardiac rhythm, vital signs, and the such. So patients are oftentimes very much more awake.
So let's just recap what Dr. Nelson said. Patients that don't appear aware on the surface may still be receiving some sensory information, including vision, auditory, and positional information. And a part of your brain called the temporal parietal area puts all that information together to make sense of it. When that part isn't working so well, the sensory information is all jumbled up and the pieces of info don't fit together. That disorganized sensory information is what causes an out-of-body experience. In fact, Olaf Blanc in Switzerland showed that you can actually apply an electrical current to the temporal parietal area to induce an out-of-body experience on demand. Just by repeatedly flicking the switch on and off in that little region, you can cause subjects to move up and down in and out of their bodies. Yet, he also mentioned the role of REM consciousness. Rapid eye movement, or REM, is a state experienced in sleep where you see brainwave activity similar to wakefulness, with random, rapid movements of the eyes, and most importantly, it's the part of the sleep where you actually have dreams. But what happens when REM activity leaks into our waking hours? Do we experience simultaneous dreaming and wakefulness? And could that contribute to the near-death experience?
Yeah, it's an incompletely understood phenomenon, but it's a crucially important one because the brain, because of its energy metabolism needs, has to have blood flow every second of its life, or our life. In fact, if 10 seconds lapses without blood flow to the brain, you begin to lose consciousness, and certainly people will lose consciousness after 15 seconds. So, maintaining blood flow to the brain is a life and death function that has to go minute to minute, and so the brain's prime purpose is to keep us alive. People forget that with all the majesty the brain participates in. People forget that. Well, it's really there just to keep us going, and so the brain is tied to fight and flight responses, and so it has to keep the blood flow going. So for consciousness to be maintained, and in fact, as I said, loss of consciousness with lack of blood flow to the brain, like in simple fainting, which simple fainting is is one of the main causes of near-death experience. So the brain is really keyed in on that, and one of the keys is, people also forget this because it seems so obvious, but if you're being chased by a lion in the Serengeti about 3 million years ago, when you're trying to scurry up a tree to save your life, you don't want to be falling asleep during that time. You want to be wide awake. And so your control of the state of consciousness is crucial to our fight or flight phenomenon. It seems so intuitively obvious, people don't think about it, but the brain can't take that for granted. It has to maintain this right physiologic state of consciousness for our fight or flight, because if not, then we become lion food. We don't pass our genes on. So that connection with the brain, in particular brainstem reflexes, those things that kind of knee reflexes, but in a much more complicated way that happen in the brain. Those things have to be intertwined. So controlling consciousness, controlling your blood pressure, all those are deeply intertwined in a very complex way. But that's what the low primitive part of the brainstem. But in certain circumstances, conditions, that with low blood flow can trigger changes in the level in the state of consciousness, and we know that with that if the brain triggers REM, which it will sometimes do, REM consciousness, while waking consciousness, the two will blend, and when the two blend, then the other elements of REM consciousness that intrude in wakiness can be paralysis. Can be visual hallucinations, seeing visions, because there's a robust activation of the visual system. That's what REM is, rapid eye movement. And you have perhaps auditory hallucinations. Out-of-body experiences is actually a well-known phenomenon with REM intrusion, because it turns off that area that integrates our bodily sensations. And then, of course, the dream narrative. The dream narrative can get triggered, during that time where the brainstem is struggling to maintain the right consciousness, blood pressure to the brain. Now, when I say that the REM system can trigger the brain mechanism for dreams during wakefulness, that doesn't mean you're going to have a dream like. You're going to have something like a dream, and the context is going to be really very, very important. So, and the other thing that feeling realer than real, what is often happens, even if you're not being physically threatened, like with heart stopping or breathing stopping or you're passing out, if you're facing danger, one of the key things is you're triggering memory, and you're triggering very profound memory. You think you're going to be dying, your memory is strongly activating. If you don't believe me, you can read Dostoevsky in The Idiot, when he describes his own personal mock execution and what life was like in this minutes and seconds before he thought he was going to be shot by the Tsar. And he wasn't shot, he was perfectly wide awake. Your memory is intensely activated. So if you have an intensely activated memory, and then superimpose on that a dream mechanism that's taking place in the brain, then you've really got you've got the mixture for some fascinating experience and very important experiences.
Obviously, Dr. Nelson's view is pretty firm that all of the phenomena relating to near-death experience can be explained by the physiological processes going on in the brain at the time that it is experienced. It would be interesting to know what his thoughts are on the famous case of Eben Alexander III, an American neurosurgeon who authored a best-selling novel based on the time when a devastating form of meningitis rendered him comatose and his brain was completely shut down, yet his consciousness persisted through another realm before he returned.
That's where the real devil is here in the details. His brain was not completely, quote, shut down for the entire experience. In fact, there have been interviews with his physicians that have cared for him that said that, no, he was clearly delirious and conscious, and his brain was functioning When he arrived, he'd been given a lot of sedative medications. His brain was very disorganized, his brain functioning. His brain functioning was not normal, but his brain was in fact functioning. We are relying on the memories of someone who had serious brain derangement and dysfunction, is that lack of normal function, to give us an accurate account of what happened to him. And where there's no evidence that he had these experiences, when his brain was, quote, completely shut down. And there's actually just one simple question that can really address that issue. And I think it's remarkable to me that more people don't ask that question. And that is, when, in the course of his hospitalization, did he have these highly unusual and very powerful experiences? And I want to make another comment on that in just a moment. We don't know when he had those experiences. He doesn't know when he had those experiences that formed the memories that he has retained of that experience. And I want to say that even if they were the greatest experts in the world, and they reviewed every sentence, every comma, every period of his medical record, every number, they can't draw that conclusion. And the reason they can't draw that conclusion is back to my first question. When did he have that experience? We know from his medical records and the accounts from his physicians that he was not completely comatose. His brain was functioning during the course of his hospitalization, and we don't know when he had these experiences. So I think that Dr. Alexander had a very powerful experience, and I think that we really need to respect the value that it had for him. And we need to respect the emotional value that it had for him and the spiritual value it had for him. I think it would be irresponsible for us not to respect the value that it has for him. But on the other hand, because we respect the value that it has for him personally and spiritually, doesn't mean we have to take his explanation for his experiences at face value, because I don't. I think he's mistaken on the basis.
Okay, let's take it back to the scene of the accident. There you are, you've been pulled out from under the sheets of metal left over from the car accident. At the beginning of the episode, we describe a scenario where you open your eyes and you see someone standing over you. But let's explore one of the other options. What if you couldn't open your eyes? Maybe you see some light, a brief glimpse of what might be going on, and maybe you can hear the shouting and smell the scent of burnt rubber. Then you pass out, later waking up to find yourself in a hospital bed. You then hear the chatter of hospital personnel and the distinct smell of the hospital corridor. You try to get up out of the bed and find that you can't move a muscle. What's more than that, you try to cry out for help, and there's no sound. You can't speak either. One outcome of a traumatic brain injury, which can result from motor vehicle accidents, is something called a persistent vegetative state. Historically, people believe that those in persistent vegetative states weren't conscious, that they weren't aware. For years, those in persistent vegetative states were thought to be in a sort of eyes open, permanent unconsciousness. They would have preserved sleep-wake cycles, which makes it distinct from a coma, and many of their organ systems still work. Their heart still pumps blood and their gut still digests food. However, it was understood that they were, as we mentioned before, permanently unconscious. In 2006, a study came out that turned this assumption on its head. It could be the case that they're more aware than we actually think. And if there is some preserved awareness, maybe we can find a way to talk to them. Dr. Adrian Owen was on the forefront of this exact shocking discovery.
That is probably the study I'm best known for. It came out in 2006 in the journal Science. And up until that point, no one had ever been able to show that any patient who was diagnosed as being in a vegetative state actually had any residual awareness. So these are patients who typically have sustained a very severe brain injury. They're often described as being awake but unaware, and that's because they'll open their eyes, but they won't respond to any form of external stimulation. So if you ask them to move a hand, they won't move a hand, blink an eye, they won't blink an eye. They have basic reflexes, but that's it. We reasoned around about 2006 that perhaps some of these patients are aware, they have some inner awareness, but they're just not able to indicate that to the outside world because of the nature of their injuries. So in that study, we put a patient into an MRI scanner and we asked her, we said, well, if you can hear us, please imagine that you're playing a game of tennis. The reason we did this is because if you imagine waving your arms around vigorously as though you were playing tennis, you activate a part of your brain known as the premotor cortex that's involved in setting up and producing movements. And sure enough, when we said to her, imagine playing tennis, the premotor cortex lit up. And then when we said, okay, now just relax, activity in that region disappeared. And then we repeated the study. We said, well, imagine playing tennis again. And again, activity in that area lit up. And on this basis, we were able to show that she wasn't vegetative at all. In fact, she was completely conscious and aware, just, I suppose, completely paralyzed, unable to express herself in any traditional way. But she could change her brain activity when asked to do so, to show us that, in fact, she was aware. The analogy I often use is we use brain activity in the same way that you might use the squeezing of a hand. Probably most people have either experienced this or seen a TV show where a doctor says to a patient, well, squeeze my hand if you can hear me. What we were doing with this patient, we were saying, well, imagine playing tennis if you can hear me. And just like the squeeze of a hand, if you can do it and you can replicate it time and time again, you can deduce that somebody can hear you, and in fact that they're in this case conscious and aware. The only types of consciousness that we really, completely understand are those of other human beings like ourselves. And the way I would assess that you are conscious would be to ask you to make a response. I might say to you, well, if you're conscious, raise your hand. And up until that point, up until sort of the mid-2000s, this actually had been a huge problem in the clinical literature, because we were assuming that patients were unconscious based on the fact that they couldn't make responses. We would say to patients, well, if you can hear me, raise your hand. And because some of these patients wouldn't do that, we would assume that they lacked consciousness. So there's this really tight link between our understanding of consciousness and responsivity. And in fact, what this study really showed is that those two things are entirely different. You can be entirely conscious, but also entirely non-responsive. And our reliance, if you like, for all these years on responsivity as a measure of consciousness was, clearly a mistake, because we now know of many cases of these patients who are actually conscious but non-responsive. So I think that's what it tells us about. It tells us more about how we measure consciousness than about the nature of consciousness itself.
Mind-blowing, right? By asking a vegetative patient who is presumed to be unaware to think about themselves playing tennis, the part of the brain involved in motor movements lights up on a brain scan. Turns out that they're not unaware after all, and can respond to commands, which is, as Dr. Owen put it, one of the defining aspects of consciousness. So if we can determine that these patients are in fact conscious, then can we actually go one step further and ask them questions?
I guess I came to understand quite a lot about the relationship between brain activity and thought. I knew that certain types of imagery could elicit certain types of brain activity. And when we set about designing this study for this one patient, what we needed to do was to come up with something that was really, really reliable. And, people have often asked me since, well, why didn't you get her to think about what she had for dinner before her accident, or get her to think about her favourite movie? And the reason is because we don't know very much about how the brain responds to thinking about your favourite movie, say. We do know a lot about the motor system of the brain and how it's organised, and we do know that if you think about moving your arms vigorously in space, you will produce activity in the premotor cortex. And we obviously conducted some pilot studies in healthy participants. I've lost count of how many people I've put into a scanner now and asked to imagine playing a game of tennis, but we did it many times in healthy people, and we showed it was extremely reliable and extremely robust, that if somebody was actually conscious, was listening to, and was able to produce a response, it would manifest itself as a change in activity in the premotor cortex. So, it just seemed like a very reliable thing to test. I guess the other factor that you need to take into account is that we needed something that people didn't have to practice. We didn't want something that was terribly complicated. We needed to just be able to say to her, imagine doing this, and it to be pretty obvious what it was we wanted her to do. And there are many things you can do when you're playing a game of tennis, but they all basically involve waving your arms around, imagining that you have a tennis racket trying to hit a ball, and that's all we really wanted her to do, because we knew that was the key to unlocking her consciousness. The second thing we did with her is, we said, well, imagine moving from room to room in your house. And we thought about that very carefully, because although that is in a sense, as you say, it does involve motor action, the emphasis of that task is rather different, and the devil is in the detail. What we asked her to do is to move into each room in her house and look around. Imagine where the TV is, imagine the pictures on the wall, imagine where the cupboard is. Think about all of the objects in the room. And again, rather like motor imagery, imagining playing tennis, so-called spatial navigation, or thinking your way through a familiar environment, is something that's been really well brain mapped. And in fact, I had done some studies on that back in the early 1990s, getting people to think about travelling from home to work, or thinking about travelling from the front door to the bedroom in their house, and looking at the parts of the brain that are involved in that. And in fact, even though there's some sort of conceptual overlap, it's really quite different. It produces activity in an area known as the parahippocampal gyrus. So it's often called the human parahippocampal place area, because this is a part of the brain that's really important for navigating in space. So when we went into that study, we really knew that these two tasks activated entirely different networks of the brain.
So not only can you ask the patient to think about doing something to establish that they're aware, but you can also ask them to think about doing two different things and create a yes-no binary that way. Imagine all the things that you could ask. Like, do you find it cold in here? Or do you like the hospital food? And to this question, I'm just going to assume that the answer is no. There are, however, more serious questions with huge, and I mean huge, implications for future care. I think you know what I'm getting at.
Many people have said to me, well, could you use this technique to ask a patient whether they want to live or die? In 2010, we published the first paper showing that you could use this technique to communicate with a patient, having the patient indicate yes or no responses. And the idea is pretty simple. We said to a different patient this time, he'd been in a vegetative state for 5 years. We said, we're going to ask you some questions. If the answer is yes, imagine playing tennis. If the answer is no, imagine moving from room to room in your house. We then asked him a series of questions, and we looked for activity in the premotor cortex, indicating that he was imagining playing tennis or saying yes, or activity in the parahippocampal gyrus, indicating that he was imagining moving from room to room in his house or saying no. He answered 5 questions in a row absolutely accurately. We started by asking him questions that there were good concrete answers to, things like, do you have any brothers and sisters? Is your father's name Alexander? Was the last place you went to prior to your accident the United States? Things like this, things that we could verify later as being correct or incorrect. And he got 4 questions in a row correct. The 5th question we asked him was, do you want to continue living in this situation? And I have to say, and again it's detailed in the book, we couldn't interpret the result. He didn't say yes or no. At the time, and this is one of the reasons we didn't publish the data, we just assumed perhaps he was too tired at this point. He'd been in the scanner for well over an hour, and he wasn't able to continue doing the imagery task. But looking back, I think I now know what was going on. And that is that there really isn't a simple answer to the question, do you want to live or die? And I suspect for most of these patients, if you ask that question, their answer will be, well, it depends. How long am I going to be in this situation? Do you have a treatment that could bring me out of this situation? Is there something that could be done to make me more comfortable? Is this method of communicating something I'm going to be able to use every day? There are, none of these patients really are likely to say, yes, I want to die, or no, I want to carry on living. And I suspect the reason we couldn't interpret his data is exactly that it wasn't a simple yes or no answer. And he only had two options. He could only answer yes or no. There wasn't a I don't know or give me more details option. There was only yes or no. And looking back and looking at some of the experiences we've had with other patients, I would guess that he didn't really know the answer.
Dr. Owen's research, as groundbreaking as it is, was met with some skepticism in the scientific community. Couldn't it be possible that the brains of vegetative patients simply retain some automatic processing of words outside of conscious awareness? So the patient's brains are simply being activated in response to the word tennis, and it's not necessarily the case that patients are actually understanding and interpreting the commands and questions they're being given. To this criticism, Adrian Owen has a response.
Yeah, we spent a lot of time working on this because, of course, after our initial discovery in 2006, many people said exactly what you suggested. Well, maybe that could just be an automatic brain response. Maybe hearing the word tennis makes people just sort of automatically think about tennis outside of any conscious awareness of that. So I could think of 4 or 5 different answers to your question. Let me just give you a couple. One is, it works even if you don't mention tennis. So, for example, if I would say to somebody, I'm going to put you in the scanner, and when I say the word go, I want you to imagine playing tennis. And then 20 minutes later, we put them in the scanner. By then, any kind of unconscious processing about tennis would be long gone. And I say the word go, and the premotor cortex lights up because that person is volitionally or intentionally imagining playing tennis. It's entirely inconceivable that could be an unconscious link between the word go and the word tennis, which we made sort of 20 minutes earlier. We very explicitly tested this some years ago in a study that, again, we published in the journal Science, where we actually asked a group of healthy participants to imagine playing tennis in the scanner. We said, please imagine playing tennis. But before they went into the scanner, we told them, we're going to ask you to do some things, and we want you to not do them. Right? So that's the instruction they had beforehand. And then lying in the scanner, we said, imagine playing tennis. And there was no change in activity in their premotor cortex. And that is because even when I say to you, imagine playing tennis, you don't have to do it. Your brain doesn't automatically do it. It's a choice you make to partake in this experimental situation. And we showed that people can even not imagine playing tennis despite being told to imagine playing tennis if they've previously been told to ignore any instructions that they were given. So this is just another piece of evidence that this is a conscious process. I guess the last thing I'll mention is that it's important to understand fMRI data, the way we analyze it. None of these responses were just sort of blips in time. This is not like she imagined playing tennis for a second. This woman and all the patients we've seen subsequently have been able to sustain this response for 30 seconds. Now, I don't know of any unconscious response in the brain that will continue for 30 seconds in the absence of any stimulation. Now, obviously, if I make a noise, say clap my hands for 30 seconds, your auditory cortex will continue to respond for 30 seconds. But if I clap my hand once, auditory cortex will respond, and then there'll be no activity for maybe 20 seconds or so. This woman wasn't continually stimulated to imagine playing tennis. She was told once at the beginning of each 30 seconds, but she was able to sustain that response for the full 30 seconds. And again, there isn't any unconscious explanation for that behavior. That's something that can only happen if you are consciously willing it to happen.
Over the years, Dr. Owen has scanned and examined thousands of patients. That's thousands of real people whose lives were irreversibly changed forever. While we couldn't possibly begin to appreciate what this all means, we wanted to know what the stories were that stuck out to him the most over the years.
So I guess the stories that stick out most for me, the patients that stick out, are the 10 or 11 that I chose to put into the book. One in particular is a patient that we saw who came to us, appeared to be completely vegetative. He was a young man, he was 19 years old. He had a brain injury, an anoxic brain injury. He appeared to be vegetative, non-responsive for some months. We put him into the scanner, we saw nothing. We asked him to imagine playing tennis, we saw nothing. We tried EEG, electroencephalography, we tried nothing. Everything we tried, nothing worked. So I sat down with his parents and I said, I'm terribly sorry, all I can tell you is we found no evidence that your son has any awareness at all. 9 months later, my research coordinator called his patient's mother, and she said, how is he getting on? And she said, well, why don't you ask him yourself? And he came to the phone, and he was speaking, and he was walking, and he was able to tell her that he was recovering very well. I've never seen anything like this at any other point in my career. This sort of recovery over about a 9-month period, where somebody has gone from appearing to be entirely vegetative to he took himself back to school in the end. It was completely extraordinary. And we brought him back here to London, and we said, well, let's see if he remembers anything from when we scanned him. And this was really the most extraordinary part of this story, that this patient could tell us everything about being scanned. He remembered who had scanned him, he remembered what sort of voice that person had, he remembered that I was English, I had an English accent, he remembered that the colour of the EEG cap we put on him. All of this information from 9 months earlier he could perfectly recall, proving, I think, beyond any doubt that he was absolutely conscious at the time, despite all appearances to the contrary. I think some people, I never want people to go away with the impression that any of our work suggests that all vegetative patients are actually conscious. That certainly isn't the case. Of all the patients that we've seen over 20-25 years or so, about 1 in 5 of them turn out to be able to imagine playing tennis in a scanner or imagine moving around their house. The other 4 we see no responses in. So now that's not a small number, because there are hundreds of thousands of these patients around the world. So we're still talking about a lot of people. But I always try and emphasize that this is a minority of the overall group of patients are actually in this situation where they might be actually aware but appear not to be.
In this episode, we took you through the hypothetical journey venturing into the borderland between full consciousness to decreased consciousness to being in a vegetative state. We explored some of the most perplexing and fascinating phenomena known to the human experience. The near-death experience, including the out-of-body experience and feelings of intense spirituality, push us to question our understanding of consciousness in human life. While the argument of whether the near-death experience can be physiologically explained or if it all boils down to faith is still going on, Dr. Nelson has taken the hardline stance that the basis always lies in the biology, and the evidence is growing. Near-death experiences also bring up questions about the nature of consciousness itself. While research has uncovered a huge amount of knowledge regarding human consciousness, there is still much to learn. We can agree though, at least in the case of the vegetative state patient, that consciousness isn't always what it seems. Thanks to the work of Dr. Adrian Owen and researchers studying states of altered consciousness, we can revise the way we actually define consciousness, which may ultimately change our understanding of what it is as a whole. Thank you guys for listening. If you'd like to learn more about our podcast, please visit #healthpodcast.com and remember to like and share #health on social media. This episode was written and produced by Mary Nguyen and me, your host, Nafis Hossein. We hope you enjoyed this episode, and until next time, this is #health.